here's the genesis of the PrEP demonstration project, basically. So you probably, most or all of you have heard of IPREX, which was one of the randomized control trials of daily Truvada as pre-exposure prophylaxis.
Right.
And San Francisco was one of the IPREX sites. And Al Liu is one of the IPREX investigators. And so as IPREX was in process, it became clear that in addition to randomized controlled trials looking at the efficacy of pre-exposure prophylaxis using Truvada, there needed to be implementation studies. How would this actually work in the real world? And so as IPREX was still going on, the Division of AIDS at NIH decided to fund a number of real-world implementation studies, demonstration projects in a variety of sites. Oh, Vivek, thank you.
Thank you, Vivek.
All right. So, I'll tell you what. Well, I'm just going to load it off of my little thumb drive because I don't know where it is on this thing. So anyway, it was decided that San Francisco City Clinic, which is the municipal STD clinic run by the Department of Public Health, and the University of Miami and its associated Dade County STD clinic would be two clinical sites where a PrEP demonstration project would be started. And that was the genesis of that.
So have you already completed the study?
So, okay. So,
Thumb drive so they can put it from the
okay.
Yeah.
Thanks. All right, so I'm just going to describe the PrEP demonstration project. So the PrEP demonstration project is an open label observational trial of daily amitriptyline, tenofovir, or Truvada for pre-exposure prophylaxis in men who have sex with men and in transgender women at an ongoing increased risk of HIV infection. The recruitment goal, the enrollment goal is 600 participants, and it's divided among San Francisco City Clinic for 300, the Dade County STD Clinic for 200, and a site that was recently added, Whitman Walker in Washington, D.C. for 100. We started enrolling in Miami and in San Francisco at the end of September 2012. Whitman Walker joined in September of this year. And at San Francisco City Clinic, we are currently closed to enrollment. We have one open spot that's been scheduled, and we've basically hit our enrollment target as of, well, we will have fully enrolled as of next week. It's a 48-week trial, and we've already actually had the first 10 or so participants age out of the study.
What's the eligibility criteria?
Not so age out in terms of their participation in
I
the
see,
trial.
duration
Yeah.
of the study.
Yes.
Yeah.
What's the endpoint?
The endpoint is not efficacy. We know from a number of randomized controlled trials that PrEP works if you take it, or Truvada works if you take it. This is really a study of uptake, acceptability, feasibility in a clinic setting, and most importantly, adherence and correlates of
And how are
adherence.
you measuring adherence?
So we're measuring adherence a number of different ways. We're doing traditional pill count and self-report, but we're also looking at dried blood spot levels, intracellular levels, and also in hair. So we're looking at the intracellular levels as measured by dried blood spot, give you an approximate sense of whether Truvada has been present in the last 14 days, and hair levels give you an approximate indication of whether Truvada has been present in the last 3 months.
I figured that.
Awesome.
It's like you press that thing and it
Okay.
presses that button. But
All right.
maybe just don't touch this thing.
All right.
Yeah. Oh, wait. I don't know.
How often do they get their adherence measures?
Okay.
This is awesome.
All right.
This
Maybe
is like a talk show.
maybe do this. Just
Um,
like this. Oh my God! Wow.
I don't like to waste time.
Yeah.
This is
So
crazy.
All right, I'm just going to describe how the study works. So, participants.
Oliver, if you, these poor guys were trying to record you,
Yes.
if you keep going away from the microphone, it's torture.
I really hope they're not recording me, but okay.
I'm videotaping you as well.
Awesome.
You're gonna have fun YouTube.
I do this thing on stage when I'm thinking I close my eyes, so I hope I don't do that. Someone warn me, wave your hands if I start doing that. So our participants come from two sources.
I think I know the problem.
Okay.
This is only one slide,
Okay.
so it's ending. It's going back to that.
Okay. So where's my talk?
Is it on this?
It is.
Okay.
Okay. So we get our participants from two sources. People self-refer, they present to the registration desk at City Clinic saying, I've heard of PrEP, I want PrEP. And the others are recruited from City Clinic during City Clinic visits. Okay, all right, let me, thank you.
How do you determine, you said that they're at high risk, so
Right. There we go.
I'm sorry, your time's up.
Fantastic.
Let me get this. I'll get this.
Actually, seriously, how much time?
Here's the person, voila.
Hi. How much time do I have so I know where to cut in?
10 minutes?
10 minutes?
It's like,
Is that all right? How long is this session?
Okay. No, it's not projecting.
3 o'clock.
Okay.
Yeah, that's fine. 10, 15 minutes.
Try using the arrows. Let me see if I can get the projector.
We're still at the question and answer? Okay.
So people either self-refer or they're identified in the course of a City Clinic visit when they're coming for STD services that they might be eligible. And the eligibility criteria are pretty straightforward. You have to be a man who has sex with men or a transgender woman. You have to be older than 18. And you have to, in the last 12 months, either 2 or more episodes of unprotected anal sex or anal sex with two or more episodes of anal sex with an HIV positive partner or partners, regardless of condom use, or a rectal STD or syphilis. It's not and, it's any of those make you preliminarily eligible. So that's the pre-screening process. And if you pass the pre-screening process, you're screened for hepatitis B surface antigen positivity. Those people who are hep B surface antigen screen out. A creatinine clearance of less than 60, and then a battery of HIV tests, including a rapid HIV antibody, a 4th generation combined antigen antibody test, and at City Clinic, unlike the other 2 sites, we do pooled RNA testing as well to weed out people with antibody negative acute HIV infection. Okay. So,
So we got this. Can't figure out why it's not.
okay, so I'm just going to keep
wanna just
describing.
talk
Yeah,
through
I'm
these?
just going to talk.
Yeah.
So,
It's
Go
fine.
back, guys.
oh, fuck. All right. Sorry. You can bleep that. Also at baseline, besides the testing I described, people get behavioral screening both for drug use and and sexual behavior. They come back approximately 2 weeks later for enrollment, at which time they get the same battery of HIV testing, and they get adherence counseling and instructions on how to use Truvada and their first bottle of pills. They come back 1 month later for a 4-week follow-up. They get HIV testing again, a symptom review, adherence counseling, and 2 more bottles of pills. They come back 2 months later, and all their visits from there on until week 48 are quarterly visits, at which time they get behavioral assessments, drug use assessments, adherence and behavioral counseling, HIV testing, and creatinine level. And they're enrolled for a maximum of 48 weeks. So one important thing to talk about is why we chose that testing regimen. So as many of you probably know, in the randomized control trials of Truvada for PrEP, IPREX and IPREX and TDF2 and Partners PrEP, there were no one who was actually randomized to Truvada and got infected had resistance mutations. The people who ran into trouble with resistance on PrEP were people who were actually surreptitiously acutely infected at the time they started their Truvada. They were antibody negative and RNA positive. And the way the randomized trials were conducted were participants got monthly visits, including a rapid HIV antibody test, and then got their pills. And they got blood banked for RNA testing as well, but it was only, those tests were only run retrospectively if someone tested rapid positive. And that was done to determine their earliest date of seroconversion. So that's how it was possible to actually enroll on Truvada with an antibody-negative, RNA-positive acute HIV infection. And those are the people who had a higher risk of developing resistance mutations to either of the drugs in Truvada. So the way the demonstration project is run is we have this two-step testing process for screening and enrollment to find people who might be very, very, very acutely exposed, either right before their screening. And we test them both with a rapid antibody, which needs to be negative for them to receive a bottle of pills, and more sensitive testing for acute infection, the fourth generation test and the pooled RNA in San Francisco, to look for those few people who might be acutely HIV infected with a negative antibody test. Because we really want to avoid the possibility of putting people with HIV infection onto nucleoside analogs. So what else can I tell you about?
So how far, some people have already completed 40, where are
Yes.
you in enrollment?
We're basically fully enrolled. There are a few people who've not come for their enrollment visit, but those enrollment visits are scheduled. And Whitman Walker has already enrolled about 25 people, and Miami has enrolled between 100 and 200 people. And we've had some people finish their 48 weeks already.
What has the level of enthusiasm been in terms of participation?
Right, so I wish I could share with you some of the preliminary data on adherence and behavior and all that stuff. I can't, it's actually kind of embargoed. But I can tell you that uptake overall in the study across all 3 sites has been between 50 and 60%, slightly higher in Miami, actually slightly lower in San Francisco. That's kind of an artifact of 2 slightly different screening and enrollment processes. But overall the uptake has been good among people who are found to be eligible. And we're looking at the breakdown of uptake between people who self-refer and people who are clinic referrals.
Okay, I have a question.
Sure.
Yeah, can you comment on the age of the cohort? Because in IPREX we had really young
Right.
folks.
I can't give you precise numbers right now. In San Francisco, it's in the 30s. The median is in the 30s. And we have quite a spread. We have some who are just 18, 19, and we have some into their 60s as well.
Are there any data on your slides?
Oh, my slides. Let's see.
Let me,
Yeah.
you're doing intermittent counseling sessions throughout, right? So
Yes.
how does that impact real world, your definition of real world setting?
That's a great question. I think the role of counseling right now is very fraught. I think particularly with the release of the AWARE study data a couple days ago, I think everyone's scratching his head about what is the role of counseling at a population level. I think there's no doubt that counseling can be extremely effective for individuals. I think we don't really know at this point the role of counseling in behavior change for HIV.
Can you elaborate on AWARE for those of us that missed that?
Right. So AWARE was a study of rapid HIV testing with or without patient-directed risk reduction counseling. And the endpoint was STD acquisition. And there was no difference in the 2 arms between people who got rapid HIV testing alone and rapid HIV testing with partner-directed counseling. And that was just released, and that's a very general overview. So I think that finding still needs to be digested. But I think it
It was what? Oh,
sorry? So what, and your question was, what's the role, what do we think the role of counseling is
Well,
in the real world setting?
Yeah,
Yeah, how does the
Right.
fact that you're providing counseling throughout impact your definition of real world?
I think it's a really good question. I think, we don't, I think our counseling is very streamlined. I think what we will what I hope we'll do with the counseling is come up with a very provider-friendly sort of counseling guidance. I honestly don't know if, as PrEP is being rolled out since its licensure, whether providers are doing risk reduction counseling or adherence counseling. And I think we really don't know the role of adherence counseling in PrEP, given the results of the successful and the unsuccessful randomized control trials of PrEP, mainly done in Africa.
so do people get laboratory results during the?
They don't. So this is a
It's not like 052.
It's not like 052. So this is the question is, do we, in a sense, confront participants with data on their adherence, objective data on their adherence from the drug levels? We don't do that. We're not doing real-time reporting. We're doing real-time collection and then subsequent analysis.
It's more real world.
Yeah.
If people have questions, we can't see you, because there's a light in our eyes, so you just have to shout.
Are there other questions?
Any follow-up after the 48 weeks if people still want PrEP?
Yes, so that's a really, really important issue. So the first thing is people stop their Truvada at week 48. They come back for a 48 plus 4-week visit because we're interested in what happens to their behavior and potentially to their HIV infection risk in the 4 weeks after they stop their Truvada. We start asking participants at week 36, so 3 months before their end date, if they want to stay on PrEP after the trial and if they're making plans to get PrEP after the trial, and we work with them to troubleshoot around that. That has become much more of an issue than we realized.
Because,
For a number of reasons, actually less having to do with insurance access, interestingly. So a lot of private insurance will cover PrEP. Kaiser, which provides care to a lot of people in San Francisco, will provide PrEP. Healthy San Francisco, which is the citywide health plan, will provide PrEP, will pay for drug coverage. I think there is more of an issue with finding providers who are comfortable prescribing PrEP, whether that is because they do or don't believe in it as an ethical prevention intervention, or whether it's because they don't feel comfortable prescribing an antiretroviral drug that they don't typically prescribe. So the majority of people who prescribe PrEP to HIV negatives are not going to be HIV providers. And it's very easy for me, I'm an HIV provider, it's very easy for me to write a prescription for Truvada. I know the drug inside and out. But if you ask me to prescribe Cytoxan or methotrexate for someone's rheumatoid arthritis, I would be extremely nervous because that's not a drug that I prescribe on a routine basis. And I think a lot of primary care providers may find themselves in that position of being asked to prescribe a drug that they have heard is toxic and they're not intimately familiar with it. So one of the things we're doing now, as this has come up, more of an issue, is we've designed a provider readiness survey. And we're actually going to email it out to primary care providers. There's a network of primary care providers in the Bay Area as a needs assessment. What are they prescribing PrEP? What are their barriers to prescribing PrEP? Who would they prescribe PrEP to? What sorts of education and training do they need to do it comfortably? So I think the next step is going to be, this is the demonstration project has been focused very much on patients. I think a crucial next step is going to be focusing capacitation on providers.
are you looking at whether people are giving the drug to anyone else or any black market
We are,
stuff?
yeah.
Yeah.
So at their quarterly visits, we ask about what happened to the pills. Yeah.
If Gilead if this was a brand new drug being marketed for PrEP, it would never have been priced the way it is currently priced. And unfortunately, it's not a drug just for PrEP.
Right.
Has there been any discussions about repositioning its price point with respect to PrEP, either more generally thinking that, how big a piece of their overall market could PrEP be, And second, I'm talking about within the US, obviously, internationally,
Right.
completely different
Right.
discussion. Have you guys thought about, the pharmacodynamics may be sufficiently different that would justify a different dosage formulation?
Right.
That would then differentiate the products as the industry is so happy to do in so many other spheres?
Right. I don't know about any discussions that have happened inside Gilead about that. I have heard that they don't expect to profit from Truvada as PrEP, but that's just hearsay. I haven't actually talked to anyone about that. The dosing question is very interesting, and Bob Grant isn't here, is he? No. Okay. Sorry?
He's not getting it.
Yeah. There's a Gilead PrEP meeting going on right now, but it looks like if you correlate drug levels with the dosing scheme needed to achieve that level and efficacy, it looks like if you take Truvada anywhere from 4 times a week to 7 times a week, you get above 90% efficacy. No one is actually giving that guidance to patients. We recommend daily Truvada. I think the messaging around non-daily use is difficult. It's hard to take a pill daily. It's probably even harder to take a pill not daily.
But that's the opposite of what I was saying. In other words, an 80% dose daily
Right.
would create a different product, which could be priced completely differently.
That's right.
And,
Although I wonder how much of the price is actually the components of the drug
no,
versus,
that's exactly my point. Almost none of it.
yeah,
So therefore, you could imagine a drug that costs 1/3 as much,
Right.
with 80% of the drug,
right,
or whatever,
right,
and is potentially therefore a mass intervention
yeah,
that doesn't depend upon an exceptionally enlightened Kaiser.
right,
That doesn't translate nationwide.
right, right. Sure. I think also, I mean, taking off from that point a little bit, I think we're looking at first generation PrEP right now. Alternate dosing strategies and certainly alternate drugs are definitely being investigated. Oral drugs with fewer potential long-term side effects. And what's most exciting is the potential for an injectable depot drug that removes daily adherence from the equation altogether. I probably have to stop, but
Yeah.
One last question
Yeah.
from Chris, and then we'll move on.
Given that we've, heard some people talk about this today, is there any part of your, this is great stuff, by the way. Any part of your assessment that has a more qualitative aspect to it in terms of talking to participants about their use and
Yeah.
a number of different dimensions?
yes, so I failed to mention that, I'm sorry. So at the quarterly visits, participants see a clinician mainly for safety monitoring and symptom monitoring, and they also see a counselor. And it's the counselors who administer the adherence questions and the sexual behavior questions and the drug use questions. And they also conduct more free-form conversations about people's sexual behavior in the previous time interval, effect of substance use on that, effect of taking PrEP on, if they think there's been an effect of taking PrEP on their sexual behavior, where PrEP fits into their prevention plan, and any related concerns. And those are all recorded in free verse, essentially. And so we're actually asking a PhD anthropology student to do more qualitative analysis of those transcripts. Because and I've done some of the counseling sessions, there's incredibly rich information there. Yeah.
Thank you so much for
Yeah.
such a great presentation under such difficult circumstances.
Thank you for being such awesome and gracious interviewer. I'll come back to your show anytime.